Thank you very much, Christina, and thank you all for being here. As was mentioned, Christina, you read that just like my mom wrote it. Thank you very much. Coming from Central California into East Texas was quite a bit of a change, and one of the very first things that we noticed was a wonderful culture of kindness that is embedded in people that are here, folks that are here, in y'all. And that was one of the first things that we had to learn how to say y'all in the proper context. Yeah, and that's absolutely true. We're so grateful to be here. Of course, all the stuff that was done that you heard about was done back in California. And so what we're trying to do, both my wife and I, is reestablish ourselves in our professional lives and also especially in our ministry lives, to get things rolling here. So one of the things about the history that you heard about was for the entirety of my career, I worked for a single entity, one pediatric hospital, freestanding hospital, that for the last 20 years of my career, I oversaw the trauma program there. So trauma, by definition, are all the kids that are injured. So hit by cars, falling off their bikes, and unfortunately child abuse. Back in 2012, there was something that came across our radar that had to do with kids that were unfortunately dying by suicide, something that we really weren't addressing at that time until we took a closer look at it. I remember we had one case that came across that our program, a child who hung himself, succumbed to that suicide, and then just 2 weeks later we had an 8-year-old. So my colleague and I got our heads together. We developed a concept of what we wanted to do to address this issue that was not being addressed within our community. At the same time, within a year's time, there were 3 suicides of high school students from the same high school. In addition to that, and looking further into the situation, we found that there were 2 others that were alumni of that high school, bringing the total number to 5 within a year of that one high school. So what we did is we brought together a multitude of agencies within our locale, and we first had a conference, a 300-seat capacity conference that sold out within a day or two. And we brought all those heads together. We were able to share with one another our concerns, but mostly our expertise and perhaps how to deal with all of this. That coalition, I'm very proud to say that it grew beyond our capacity, and it went county-wide and region-wide. From that, they developed a charter for the county of Fresno on dealing with teenage suicide, inclusive of not only agencies, behavioral health agencies, but also education, medical, and so on, including parents. And so now, if you're interested in taking a look back at what we did in California, go on to fresnocares.org, fresnocares.org, and you'll see the culmination of the work that we've done that is continuing to go and inspire folks. Overlaying that, at the same time that was happening in my personal life, my wife kept coming to me and saying, hey, you know what, you've got something going on. There's something that's not quite balanced with you. There's something that's happening with you that I don't know what, I can't put my finger on, but you've got something going on, and I think you need to go to see help. And like every husband that is perhaps in this room, I responded with, nah, I'm okay. There's nothing wrong with me, I'm fine. A couple of years go by, I start noticing symptoms. And of course, being the medical professional that I am, of course, I had to go to WebMD in the middle of the night and started looking up symptoms for depression. And lo and behold, I got that, I got that, I got that, I got that, I got that. And then in the middle of one of these nights in November of 2013, again, I had to say the thing that no husband ever wants to say. She's right. And so when that happened, it got the ball rolling, and I was able to come out of that into recovery, because those of us who have had to deal with depression know that it really kind of lingers forever. but we learn how to deal with it and keep it under control. And so fortunately, for the last several years, I've been symptom-free, essentially. So thank the Lord for that. Now, overlaying all of that is with all the stuff that we did through the hospital, I also went outside of the hospital and worked in the ministry for the Diocese of Fresno and developed this Be Not Afraid presentation or talk, what I prefer to call a discussion. We went out into the community and we had over 2,500 youth and parents and groups. Particularly, we responded to confirmation groups, youth groups, young adult groups, college kids, and the like of that target area. Because the data that we found, we collected some additional data specific to Catholic youth, we found, lo and behold, same exact stuff as we found in the schools, right? That depression and suicide were the #1 concern of all the kids in that region. Come to East Texas and find out that, well, lo and behold, there's a problem here too. And in fact, because of our wonderful culture here in East Texas, we may be a little bit behind in, I don't want to say behind, we may have more opportunity to address this issue because of certain differences between the likes of California and Texas. And that's where I'm going to need y'all's help in responding to me and how to perhaps find a way into the culture and to appropriately get the word out and try to be sensitive to the folks that are living here, because being the California dude coming on over, I cannot step into that and automatically assume the role of somebody that maybe is as well knowledgeable as the culture is here. Eventually, I hope to get there, but I'm not there yet. All right, so that's a big old giant introduction, and let's just go ahead. All right. Okay, so here we go. So the first thing I want to point out is a 3-digit number up on the upper right-hand corner of that screen, 988. That's my attempt to subliminally inflict that number into your subconscious level. Okay, and we're going to talk about that number as we go along more towards the end of the talk. So you'll be seeing that number pop up on several of the slides that I'm presenting to you, 988. What are we here for tonight? Well, what we're here for is we are here to address the issue of teen depression and suicide prevention by raising awareness that, first of all, it does exist and that it is prevalent in our region here. We want to identify the signs and symptoms in order for us to be able to recognize it. And then we also want to learn a little bit about how to intervene once we recognize it. In addition to that, we're going to provide some resources so that once we intervene, we're not the ones that are going to fix this, right? We recognize that a teen might be going through this issue. We're not going to be the ones to fix that problem. What we are going to be able to do is provide love and hope and send them on their way so that they can get fixed. Okay. All right. And then most importantly, I hope to instill hope in all of us, but also have the opportunity to provide hope to people who need it. This is not a training session, nor is it by any means a counseling session or a group session like that, but rather it's an information providing session so that we can take the first steps into learning more about what we can do to help these folks along. Suicide does in fact happen. There's no getting around it. Even though we may want to not talk about it, it does happen, and it's going to happen whether we talk about it or not. What we do find is that talking about it does actually help. So that's part of the thing about having to get over the stigma of what we're concerned with regards to suicide and not worry so much about saying the wrong thing. And that's what we're going to talk a little bit about that a little later. Today's talk might trigger some emotion in you. If it does, I encourage you to go ahead and find your loved one to speak about it. Don't hold it in. Go ahead and express yourself. You can certainly, if it's to a level of being malignant, hopefully it isn't, or even disturbing, that you have someone that you can go to speak with, a counselor, one of your clergy, a priest, a good friend, somebody to express yourself to. Don't hold that in. And in fact, I'll be here afterwards too if you need to speak with me. If there's at any point you feel like you're becoming overwhelmed, please feel free to get up and stand in the foyer for a minute or two until you feel like you can come on back. Okay? Because by no means do I want this to overwhelm anybody, but it is a touchy subject. So this is the data. What you're looking at here is a graph of the Centers for Disease Control. They come out every few years and provide the top 10 causes of death across an age spectrum. You see I've cut it off at the top 5. But the blue boxes, for example, say unintentional injury. You see this goes all the way back to age 1, all the way through middle adulthood. So that's trauma. That's the world that I used to live in. So that all those blue boxes were all the things that I was trying to address back in my previous life, my previous professional life. The green boxes are what we're here to talk about tonight. The green boxes are suicide. Red boxes are homicide. So the green boxes, as you see there, begin to show up at age 10. You recall what the 2 circumstances I told you that catapulted us into getting into this topic, into addressing it. Okay? The first one at age 12, the next one was age 8. And we saw several after that. I will point out in age 15 to 24, the homicide and suicide rates actually are only about 100 persons apart. So these have flipped back and forth over the last several years. And I will tell you that in Texas, the suicide rate is actually in the 2nd level. So specific to Texas, all 3 of these boxes here are green as a second leading cause of death for kids and for teenagers. This data right here was specific to the children's hospitals or pediatric facilities, much like the one that I work in, and we saw that that was true also. Going across the time spectrum, 2016 all the way through 2022, and of course this data is continuing now, of course. But you see that incrementally it continues to increase. Now there was a spike right here between 2020 and 2021, and I've circled those dates. Something very significant happened during that time. What was it?
COVID.
COVID? Sorry, I never heard about that. What is that? Yeah, you're absolutely right, COVID. So COVID played its ugly hand into our suicide rates as well, specifically towards teens. So that'll be something I'll be addressing in just a minute. Okay, the first thing I want to tell you about is, one of the other things I want to tell you about is that I use a multimedia approach. So I will use video or pictures to illustrate an issue or a topic as best I can. It's much better to show you than it is to tell you. This first video, and as you see there, I'm hopefully providing a disclaimer enough to get your guard up a little bit, is a PSA, a public service announcement that was done by a group in Louisiana a few years ago to illustrate the horrors of suicide, as if we couldn't imagine them. But it drives home several teaching points, which I'll be alluding to throughout the rest of this talk. So it not only helps with the data, but to remember that each one of those tick marks, each one of those digits that comes up on that data sheet is a family that has been affected by this very ugly, horrific thing.
Emergency 911. Help me, my brother's dead. What's your name? Mickey. What do you mean by your brother's dead? He killed himself. How did he do it? With a gun. Okay, are you home alone? Well, I'm home alone with my sister. Okay. Get someone here quick. Did you just find him, Mickey? Yeah, no, he's dead. Mickey, stay on the phone with me, hon, okay? Why'd you do it? Mickey, I've got help on the way. You just wait a minute, okay? Quick, please. Mickey, don't hang up on me, okay? I won't. Just quick. Quick. doing well.
Please hurry up and get here.
Okay, they're on their way, but you're...
My God in heaven, Jesus Christ.
Okay, you're there with your daughters, though, right?
Yes, I'm here.
Okay, I just wanted to make sure nobody could hurt them. They were so upset.
Oh, my God.
Okay, but they are on their way, okay?
Okay.
Okay, bye-bye. Washington 216, the father's on the scene now.
It may be a little girl, there were two girls that were there that found their brother. But little Nikki said that herself. Why did you do it? And that's usually one of the questions that pops up, is the why. Well, the answer is that it's never one causal factor. It's not just one thing, but rather just like the little illustration shows up there, it's a mosaic of things. It's a lot of different puzzle pieces that come together that has a person predisposed to acting out in that way. And let me explain a little bit more in depth about what I mean. So here you see four things listed up there. Genetics and biology, environment, temperament, and life experiences. We'll go through each one of these. First of all, genetics and biology. So without getting too technical and too deep into the physiology of the brain, because Lord knows I cannot do that. But when we're talking about the brain, we're talking about different brain cells or neurons. And each neuron has an extension that comes off of it called a dendrite. The dendrites have these connections called synapses. So when the neuron fires off an electrical brain impulse, it has to communicate that to the next neuron next to it. And so it does that by this means of sending off these impulses down the dendrite to the synapse where it connects. Now the synapse doesn't actually touch. It actually is very close together, obviously, but they do not touch with one another. They're not connected with one another. So there has to be a way for that electrical impulse or that brain impulse to get from one cell to the other. The way that it does that is through something called a neurotransmitter. These are little chemicals that help that transmission of that impulse go through there, just like what you're seeing there in this illustration. The blue balls represent a particular neurotransmitter known as serotonin. There are actually three of them. There's dopamine, norepinephrine, and serotonin. Serotonin, if it becomes imbalanced, can predispose that person physiologically to having depression. Doesn't necessarily have to happen, but it can predispose them to that. So there's the genetic and biology part of it. The other thing about that is this also can be genetic. It can be inherited from our parents. So we know that if a parent has been established in a mental illness of some sort, including depression, that can be passed on. Not necessarily has to be passed on, but it can be passed on to their offspring and so on. The good news about all of this is because we at least understand some of this, is that medications have been developed to offset this imbalance. One of the very first medications that comes to mind and is usually utilized is something known as an SSRI, or a selective serotonin reuptake inhibitor, an SSRI. What the SSRIs do is help that transition of the neurological impulse in the synapse by maximizing the utilization of serotonin. Okay. And that's about as far as I can go. We would have to have a pharmacist or a researcher come in here to tell you a little bit more specifically as to how exactly that does that. Although there are some explanations on the internet if you're interested in delving into a little bit deeper. So in addition to that, we have to think with regards, especially with regards to our topic today, the teenage brain. Okay? So the teenage brain has all of this stuff going on. Okay, that's normal neurological behavior development. In addition to that, we all have a little tiny peanut-sized organ known as the amygdala. And the amygdala is a portion within the midbrain, within the middle part of our brain, within the limbic system, which is also known as the reptilian brain. That's the very first, most basic part of all of our brains. It's the first part that becomes developed in utero. And so by the time the child gets to teenhood, the amygdala is pretty much well developed. Well, the amygdala is responsible for emotion, and it directs our brain in how we're going to be responding emotionally to a stimulus. I don't know about you, but I can't think of any teenagers that have that response, can you? That's a joke. Yeah, so we all know the teen years are highly emotional, okay? And this is one of the reasons. Of course, there's also the overabundance of hormones that are leaking out within their body, but it also, with regards to emotional response, okay, that's part of their entire development, is that emotional response. And this little guy is the reason for that. In addition to that, we all have something known as the prefrontal cortex. Now, the prefrontal cortex sits right in front of the cortex, just like the name implies. The prefrontal cortex, unlike the amygdala, is the last thing in the brain to develop. The prefrontal cortex is responsible for what we call executive thinking. Executive thinking are things such as goal setting, knowing right from wrong, making judgment, planning, critical thinking. If I do this, then this is going to happen, and that might happen, and this might happen. Okay. Those sorts of things. The prefrontal cortex in women matures at the age of roughly around 22 or 23. In men, it matures in the age of 67 or 68. Well, I'm glad you got that, Jim. Yes. Actually, in men, it's a little bit later, okay? More like 23 or 24, but you get the gist of it. Okay. So now, if you look back at teenage life, now you realize, oh, sure, well, that's why they do stupid teen tricks, right? That's why the guy is car surfing on top of the car, and why they're utilizing drugs to get high, and trying to find out how this thing might work, even though it might take my arm off, that sort of thing. But it's why they eat Tide Pods, or they used to anyway. But anyway, it's all those sorts of things is because that prefrontal cortex is not yet mature. So you put all of that together, just the biology of it, well, yeah, we can see how certain things might be exacerbated within the teen years that maybe somebody that's more mature, that has more life experience, can kind of deal with. Okay, temperament. Temperament is one of those things that is both hardwired in us and also a learned behavior. So temperament is essentially how we respond or cope with stress, how we cope with everyday situations within our lives. We can choose to respond a certain way, but initially our initial inherited response is probably automatic and reactive. But we can learn to kind of temper that back. I like to use the example of two of my sons. We have, Sally and I have 4 boys. All of them are now grown men, very proud of our boys. We have 2 of them that are in the military right now. Anyway, two of our sons, our number 2 son, has a temperament that is kind of laid back. In fact, when he was little, I used to call him the Prince of Cool, because he was so chill about everything. He didn't get overly excited about things, and he would just kind of go with the flow of things, and he was really kind of cool. Anytime there was conflict, he used to recede from that. He would withhold from that. He didn't want to be involved in conflict, and to this day, he's like that. Our number 3 son, reactive, right? You can get in my face, you can get in my face, that sort of guy. Had him out in the soccer field, oh my goodness, had to pull him off so many times because he would just get too involved physical with it, right? Played football, did the same thing. But as he grew up, he's one of the 2 that joined the military. And he's actually, looks like he's going to make a career out of it. He just finished 6 years and re-upped for 4 more. He and his wife both are in the military. So 2 different boys, same exact family, same genetics behind them, 2 different temperaments, right? So all of us have that separate type of temperament as to how we're going to respond to stressors and how we're going to cope with life as it goes along. Environment. So what the picture before that showed was something known as adverse childhood experiences, ACEs, ACEs. ACEs were first began to be understood way back in 1995, I believe the year was. Dr. Vincent Folletti, a Kaiser doctor in San Diego, California, began a very long study, very large study, tens of thousands of individuals that he began taking a look at. And then, of course, the team expanded, and the study is continuing on to this day. ACEs, adverse childhood experiences. What they found was, and this should be really no surprise to any of us, is that as a child experiences these adverse situations, those adverse situations develop into lifelong health-related issues, both physical and mental health-related issues. So things such as the obvious, mental illness, depression, bipolar disorder, that sort of thing. But also physical ailments, such as organ disease, heart disease, and that sort of thing. So he was able to tie those adverse situations into all of those elements later in life. So the adverse situations a lot of times have to do with violence. So violence in the home, either interpersonal violence, domestic violence, child abuse, also has to do with abandonment, parental abandonment, loss of a parent either to death or incarceration, and the list goes on and on. So depending on how many of those ACEs, of those factors that a child experiences, exponentially causes additional problems in that child's life later on as they go into adulthood. So the idea is, well, we got to really curtail those ACEs, right, in a child's life. No brainer, very hard to do. Here I show a couple of examples. Is that remember I talked about violence? Well, not only is it violence within the home, but it can also be societal violence. So going all the way back to the 60s, when I was a kid, we had the Watts riots and civil unrest, right? Civil unrest because of the blatant racism that was happening during that period of time. I was in my, I don't know, maybe, how old was I in 68? I was 10 years old in 68. And so I think all of us who were there saw for ourselves exactly what was happening. But those effects, even if we weren't there in the middle of a riot, we saw that on television. It still affected us. Assassinations. John F. Kennedy's assassination is my very first memory of life, is seeing that on the news and watching my mom break out in tears. That's my very first childhood memory. So that added into my own issue of my own lifelong depression. But in addition to that, look at what's happening now. We still have those civil unrest. I mean, to this day, you know, the agitators and going through the campuses right now. Rodney King issues, the Black Lives Matters protests that turned into riots. January 6th turned into a riot. But the list goes on and on. Okay. In addition to that, the COVID years, right? What did we do with our kids? We locked them up. We isolated them. We taught them fear, right? Now, as that medical professional that lived through that, I can't say that, I can't be too critical about our response to any of that because we were trying to protect a lot of people, but at the same time, we were in fact doing some harm. I've also thrown up another picture here that perhaps can get some argument to me. And I clearly show some trans people reading to kids. Now, is that violent? Not necessarily. But it does add a potion of confusion to a young mind. And the more that we're learning about it in truth, is that, this is not a healthy way to go, right? Life experiences is the fourth thing. So this is usually the thing that can push the person over the edge, okay? You've dealt with all these other issues, maybe the biology part of it, the genetic part of it, the environment, the temperament, and then now you couple all of that with whatever life experience is going through with them. So usually it's a form or a sense of loss of some form. Okay, so like we had mentioned earlier, maybe a loss of a parent, the death of a friend, of a good friend, particularly if that friend committed suicide themselves. That's a problem because that also adds to the potential. Stress or anxiety with regards to schoolwork, having that expectation, the expectation of being within that perfect society. Bullying certainly has made its headway on that. Okay. And that certainly does play a part in a lot of it. I know that there were several situations that happened here locally that had to do with that. Certainly drugs and alcohol. Drugs and alcohol is one of those chicken or the egg things. Which came first? Was it the depression or the mental illness that came first? And then the person is trying to self-medicate through substance abuse? Or was it the other way around? Well, it's a both and. It happens in both ways. Sexting, if you're not familiar with what that is, I think pretty much everybody knows what that is nowadays, but sexting and the use of the internet in inappropriate fashion oftentimes will land into those situations that overwhelm a person. We had several kids that we had to review. Part of the work that I did was we worked on 5 different counties, pediatric death review boards or teams. And so every month we would review the deaths that happened. And the suicides, we had many that had to do with kids that thought they were just sending a picture of themselves to their boyfriend, quote-unquote boyfriend or girlfriend, and found out that it's all over the school now and everybody has a picture of them naked. Right? It happened on both sexes, both male and female. And then same-sex attraction and gender confusion. We're, as a society, it's my opinion that we are doing these brothers and sisters a terrible disservice by enabling them. We know that SSRIs and cognitive behavioral therapy works in combating transgender dysphoria or gender dysphoria. We know that that works. But because of the politics involved, it is now almost impossible to get a child into that type of therapy. The issue is we're going to have to find a way in order to provide the alternative thought. And what I believe is the proper thought and the truth. In a way that is not necessarily us versus them, although they do bring that argument to the table, but rather as providing help to a brother or sister in need. And of course, that's the Christian Catholic way of doing that, and that's the art, right? That's the art of our faith, of how we can do that, and still provide the necessary means by which we can overcome what has been thrown in our lap over the last few years. And that's a whole other talk for a whole other discussing this, but from what it appears is that from the 60s, and this actually ties in with contraception during that time. Okay. Anytime we remove the element of procreation from the Sex Act, well then the Sex Act automatically becomes only pleasurable rather than pleasure and procreation. And that Pope, which Pope was it? Pope Paul or Sixth? Yeah, Pope Paul VI, Humanae Vitae. was prophetic on that. If you read through Humanae Vitae, he does essentially prophesy what will happen, and it's come to fruition. Yeah, you're absolutely right. Thank you very much for bringing that up. Okay. We know that with regards to suicide, that 90% of the people that do not only attempt suicide, but also complete suicide, are suffering from depression. I think most of us would assume that. But with the signs and symptoms of depression are a little bit different for all of us. And you were mentioning earlier about how do we recognize that in teens? Well, it's even more difficult to recognize it in teens. Even more difficult to recognize it in school-age kids. But the signs and symptoms, obviously a depressed mood, feeling sad. This is not just our Monday morning blues that all of us experience on occasion, but rather this is a prolonged, deep sadness that happens over weeks, months, perhaps even years of time. The depression I was diagnosed with is known as dysthymia, and that's a prolonged, lifelong type of depression. So it goes all the way back to my childhood. And it's identified as a quote-unquote mild depression, but I can tell you that this mild depression sure hit me pretty hard. But nonetheless, feeling sad or feeling empty, not interested in anything, no enjoyment, no longer getting enjoyment out of the things that used to bring joy or happiness to that person, withdrawal, taking themselves out of the action, no longer wanting to be part of the groups of their friends or their family, sticking inside of their bedroom all the time, perhaps stuck on that social media platform, right? Losing a lot of weight or gaining weight, losing a lot of sleep or sleeping extra. But of course, you remember, the sleeping extra part, that's normal teenage years, right? Yeah, and that's part of that development. Yeah, they do need a specific amount of good sleep, and rarely do they get it nowadays. No energy to do anything, feeling worthless or hopeless, and always thinking about death and looking for ways to do it. This doesn't necessarily happen, or all of these don't necessarily happen with every case, but they certainly are points to be recognized from individuals. Now, I skipped over this one, the agitation, the restless, and irritability. Agitation, losing one's temper, having a very short fuse. That was me, and that's what Sally was recognizing in me. And in fact, that's usually how men or boys will express themselves through depression, right? It usually comes out in a very aggressive, sometimes violent way. Fortunately, I never became violent, but I certainly lost my temper a lot of times over very menial things.
Is that why sometimes teenage boys are into vandalism?
The question is that why teenage boys are sometimes into vandalism? It can be. It can certainly be part of risk-taking also. And so risk-taking is something that's not on there, but risk-taking, like I had mentioned earlier, could be just simply the teenage years of trying to find something to do, or it could be, I'm going to take this risk because I don't care what happens to my life. I don't care if I'm going to fall off and die or whatever the case may be. So, social media, so what we're talking about. So if we look back at the timetable of social media, it hasn't been around that long. I mean, for those of us who have some years behind us, right? YouTube came out in 2005, something called MySpace. If you remember MySpace, that was one of the first launches of social media. And then Facebook came in about 2004, and of course it's all over the place now. But like my youngest especially tells me is that, Facebook is for old people. We don't use Facebook. And he's right. But it's still out there, right? And it's still causing some issues and some problems. YouTube is still doing that also. But essentially the timeline of social media, I mean, there's billions, almost 5 billion people worldwide that are using it. We were talking about the money involved with social media. I mean, it's astronomical, right? Pornography associated with that is also in the billions of dollars, just here in the United States alone. So it's a mountain that we're having to work up against. In addition to that, what this shows is social media users. And again, I planted an arrow where there was a big spike at 13 plus points here, and again, the years coincide with the COVID years, as you can see there. So of course, we were talking about withdrawal as part of the symptom, but then we forced withdrawal onto our kids and then threw them into the social media platforms without a lot of oversight within them. Kudos to you for having enough insight to do that.
And new research tonight is shedding light on the state of mental health in teens across the country. Yeah, researchers at Florida Atlantic University have found that suicide rates are climbing among 13 and 14-year-olds. The study found that suicide rates for teens more than doubled from 2008 to 2018. It coincides with more use of social media. The trend was also more common amongst boys in rural areas, where firearms are more prevalent. For more information on this, we want to bring in Dr. Sarah Wood. She's actually the lead author of this study. Dr. Wood, thank you for joining us, but why such a dramatic rise in teen suicide rates?
That's exactly what our study was trying to explore. There are definitely a lot of hypotheses. One of them, as you mentioned, is the increasing use of social media in young kids and teens. We also have been seeing such a rise in depression, anxiety, a lot of mental health issues in kids, and so at this point we started to think, well, what are the patterns that we saw in the data? But we had seen a decline in suicide from about 1999 to 2007, and then all of a sudden in 2008, now to 2018, we're seeing a really dramatic rise in suicide rates, particularly in kids aged 13 and 14. We've seen that suicide is really the second leading cause of death in teens aged 10 to 24, but it's the leading cause of death in age 13 and 14. And so why is that? We really thought that it is probably related to other factors such as potentially school stress, potentially family and relationship problems, which is always a risk factor in depression, and also really concerned about the social media use.
So it could be a combination of factors. So Dr. Wood, I'm sure parents are seeing this and thinking, well, what can I do as a parent to be more aware? So what are the warning signs? And I guess my other question is, what can schools do to be involved to help address this issue?
Yes, well, it definitely needs to be a team effort from families to schools to our communities. I think the warning signs for suicide are very similar to the warning signs for depression. So we all need to learn about how to keep an eye out for children who seem withdrawn, seem depressed, and are having any kind of socio-emotional problems. So I would just say that it takes a village, and this is such an important topic and epidemic and so tragic that we all need to work together to help all the students in schools learn about the signs so they can help each other, and we can also teach families. And I also hope that just as a society we can start to focus more on this and do more research.
Yeah, I hear you on all of that. Thank you, Dr. Wood, for your important work with that study. Thank you so very much.
Yeah, thank you. We appreciate your insight.
Where firearms are more prevalent. Does that sound familiar? So, yeah, I would say that I don't necessarily know that rural areas have a more prevalence of firearms than urban areas, especially having been through a few urban areas. I don't know about that, but I do know that the rural areas oftentimes have grown up with guns in the house and have used them properly and stored them kind of haphazardly, but now are coming to understand the importance of storing them. When our boys were younger, we made the decision not to have firearms in our house because of all the stuff that we saw coming across in front of my face in the trauma department, but also the data that came across. And when we made the move over here was when we finally decided to go ahead and get a couple of firearms. And of course my sons, especially the ones in the military, are expert users at firearms now, so it's not an issue. But when they were growing up, we were definitely concerned that the curiosity of boys would get the better of them. And of course that's for each family to decide for themselves. Teens and COVID, as we had mentioned, just basic graph of the COVID years when they hit us hard, 20, 21, 22, and then this is closer than now. This is May of this year, so we see that it pretty much is under control. But in the meantime, what did we do with our kids? You know, but again, the jury is still out. There's that part of me that says, doggone it, we did some harm, you know, when we were trying to do what was right. And then now I'm learning the politics behind it, and all of that stuff is just, oh my goodness, it's just really overwhelming, right? But anyway, I think we did something to our kids that it's going to be difficult for them to come through. We know that anytime there is a disaster, whether it's a man-made disaster or a natural disaster, that it takes a year or two before we begin seeing the aftermath of mental health issues. Usually it's a one-day or a one-moment type of thing, like a bomb going off, a terrorist attack, a tsunami, or something, an earthquake, something along those lines, where you have an event that happens, and then the clock starts ticking, and a couple of years later we start seeing the ramifications of those mental health issues coming back. Well, with regards to COVID, that was years, right? So now we're beginning to see the issues that are coming up, but now we're going to have a couple of years to go through before they catch up with those mental health issues. Yes, ma'am. Okay. And then the last thing I want to mention about all of this is the rise of the nuns. And I don't know if you're familiar with that term, but Bishop Robert Barron was great at bringing that out, what the nuns are, the non-affiliated with religion. So we know, and we know that this has been happening for a very long time now, for years, that the decline of religious identity has been happening, and so much so that it's really something that is culturally recognizable, I think, within us. But as it ties into what our topic is today, I think that getting away from our faith practices and getting away from our culture of having God within our lives is a definite factor that proposes not only cultural issues, but also mental health issues and health issues. So this right here is a graphic that shows, it says, where are the nuns, 2008 versus 2022. So I point out Texas used to be 23% that were non-affiliated. Now it's 37%. And as you see there, each of the blue colors is representative of greater than 35% of the population that is non-affiliated. So there you take a look at the entire United States, right? Non-affiliated to any sort of faith movement or religion.
Now, before I tell you why I think religion can help with this, I want to give you just a little taste of how much it can help. In 2016, the journal Psychiatry, published by the American Medical Association, had an article which analyzed the data of a massive survey that had been done of 90,000 nurses over 14 years. Huge data set. And the article that was published found a couple interesting trends, and one of those was that it found that nurses who attended church at least once a week, every week, had a suicide rate 80% lower than their peers. 80%. And given the magnitude of that impact that religious practice had on these nurses' lives, I think what it says to us is that if we're really going to make progress in helping people who are struggling with mental health issues, we have to start taking religion seriously.
What is it that makes a religious practice good medicine?
Suffering is automatically connected with meaning.
A search for the sacred, a way of transcending everyday experience.
Religious involvement affects every aspect of a person's health. Hello, my name is Dr. Harold Koenig. Welcome to the Center for Spirituality, Theology, and Health. We at the Center are a group of researchers from multiple disciplines: theology, medicine, psychiatry, sociology, psychology, and nursing. We are asking the question, is religion good for your health?
As a practicing psychiatrist, I really am convinced that you cannot treat a person who is suffering from an emotional problem and not consider their faith background, their beliefs, their values, their sense of their connection to the universe, connection to God.
As a sociologist, I began as a skeptic. And the facts are, although we cannot totally explain them, in and of themselves, religious and spiritual practices have an independent and positive effect on health.
Research groups around the world suggest that people who are more engaged in religious beliefs and practices experience less depression, lower levels of anxiety. They're more likely to live a healthier life.
We know that religious traditions matter for health. We know that religious practices matter. Physicians and researchers, sociologists, priests, imams, rabbis, spiritual directors, and others can meet and in collaboration and come out with the ability to speak and to think in ways that were not possible otherwise.
Over time, we have studied the relationship between religious beliefs and practices and depression, religion and anxiety, blood pressure, immune functioning, and a person's genetic makeup, and coping with illness, their sense of happiness and their fulfillment in life. Religion affects just about everything.
The most striking findings have to do with the relationship between religious service attendants and mortality. They live 8 years longer on average. That's pretty impressive.
We've got a medical crisis in our country, and what we're realizing is that trained professionals within the medical field cannot do it alone. We've got to partner with other groups.
The implications are vast. These findings from research could transform healthcare. If you're interested in learning more about the center and its activities, please visit our website.
Parishes that the faith expression and being involved with our faith is actually something that is healthful, that we really need. That's part of why my wife and I are both faith community nurses or parish nurses, is because we firmly believe in this, that to allow a person to express their faith or encourage them to express their faith is actually part of the health continuum. The Catholic teaching about suicide. So if we go back to paragraph 2280, we all know that we're stewards. This life is not about our own, about us, right? Our life is not our own. We are not the owners of the life that God has entrusted to us. Our lives are His life. It is gravely contrary to the just love of self. It likewise offends love of neighbor. Suicide is contrary to love for the living God. Sin is not used in that phrase, but that essentially is what we're talking about. Anything that is contrary to the love of God. And especially voluntary cooperation in suicide is contrary to the moral law. So, anytime we hear about protesters setting themselves on fire, for example, to make a point, especially if there is someone that is trying to encourage another person to kill themselves. And that has happened. That happened here in Texas from somebody that was out of state was encouraged a person here in Texas to kill themselves. However, we also have to consider the issue of mental illness playing a part in that suicide. So, grave psychological disturbances, anguish, or grave fear of hardship, suffering, or torture can diminish the responsibility of the one committing suicide. So we do have to have that sense of mercy with regards to those who are suffering from depression, especially if they're out of control depression. It is a symptom or is a finality of that disease process. We should not despair of the eternal salvation of persons who take their own lives. By ways known to Him alone, God can provide the opportunity for salutary repentance. And the Church prays for persons who have taken their own lives. So there is that part of mercy. So not only judgment, but mercy. Always go hand in hand. So the first decade of the Sorrowful Mysteries, set on Fridays, is the agony in the garden. And as we know, throughout the life of Christ, God incarnate in the human race, that he experienced everything save sin from all of us. There is some talk about, in fact, Bishop Fulton talks about this, that that in the Garden of Gethsemane, Christ took on sin and became sin. And I know that sounds like it doesn't theologically fit, but it was something that Bishop talks about in the sense that he brought all of that upon himself in order for us to win that salvation, like he obviously does in a couple of days after this. Bishop also talks about all of the emotions that he would have gone through, and that's what I've listed here. The mental agony, the sorrowfulness, the heaviness that we felt, the forsakenness, all of that is what a depressed person goes through. And of course, having to go through all of that, the joy is the resurrection that happens afterwards. So let's talk a little bit about hope. First of all, what hope is not. So hope is not, the Disney princess, oh, I'm going to find my Prince Charming and have a wonderful life afterwards, happily ever after. Hope is not wishful thinking. Oh, I want that pony for my birthday. Although we're in East Texas, so I guess that does happen here, right? But hope is not this wishful thinking. And us older folks get into this type of wishful thinking also, right? And hope is not how I feel about our Rangers now wanting to repeat World Series win. So all of this fits under that category of wishful thinking. It's not hope. Well, what is hope for us? Hope is confident expectation of divine blessing, and that comes out of the Catechism. So when I was in the depth of my depression, I often felt like I was in a cavern. I was way deep in a dark cave, and I just could not get out. However, I wasn't hopeless. That was one of the benefits of my type of depression. I wasn't hopeless. I felt worthless. I felt terribly worthless. But I knew that if I took the steps towards the opening of that cave, one step at a time, eventually I would get out. And I did. Okay? And all of those steps were the things that I'm going to talk about in a second. Okay? So hope, confident expectation. Confident expectation. It's more akin to expectation. It's more akin to knowing that something is going to happen rather than, oh, I hope this happens, right? It's knowing something good is going to happen. Whatever that is, it's probably going to come in a way that we're not expecting. Okay. And of course, it's one of the three theological virtues of faith, hope, and love. And of course, faith, again, confidence in God. Right? We have a heavy, deep confidence of the existence of God and his interplay with us as a relationship. And then, of course, love, willing the good of the other. You put all of this together, and it brings us back into the tomb. But on the tomb on Saturday, where we're anticipating something happening. Now, the people at that time, they were in the throes of despair. But in retrospect, for us, we know what happens, right? And so we can have that hope of Saturday afternoon, knowing that on Sunday, the resurrection is going to happen. And of course, it indeed does. Back in 2007, Pope Benedict XVI wrote an encyclical letter, Spe Salvi, the Saving Hope. In it, he highlights 4 areas of hope: prayer, action and suffering, and judgment. Prayer. So prayer, we're all familiar with that. But what he emphasizes and talks about is not, prayer is not just a one and done. We don't just dial up God, give our menu, or look over the menu and order from the menu and then hang up, right? It's a relationship. Prayer is a relationship. It's not just communicating on a one-off, but rather communicating throughout our lives, throughout every moment of our lives, throughout relationship and developing a strong relationship with our Lord. Being in that constant conversation with him, Action and suffering. You talked about doing something, right? Okay. Doing something on, or having that family do something on Thanksgiving where they went out and served the poor. Okay. Almsgiving. Okay. That's a form of almsgiving, right? Action. Suffering. Suffering with. Co-passion. Compassion. Right? Co-passion. Suffering with compassion. And putting that together with action, like you were just talking about. My compassion for these folks who are down on life, but we're providing them with something, some kind of hope. We're giving them the love. We're willing the good of the other. We are willing their good. And we're showing that through our actions. Judgment. Ooh, there's that big J word, right? The J word that has gotten such a bad rap in our lives, especially these days. It's judgment. We're supposed to judge. My goodness. How do I know? Okay, so I have a guy come to my door, somebody out of the ordinary says, hey, I ran out of gas, I need your credit card. Oh, really? Am I going to give him my credit card? I just made a judgment. No. I might give him some gas. Here, look, I got a gallon of gas here. You can have that. But I'm not going to give you my credit card, right? Okay, I just made a judgment. That's not the judgment that we're talking about. That is prohibited, essentially. What the judgment that is prohibited is the same judgment that Adam and Eve wanted by becoming God themselves. That's not the judgment that we want to do. The judgment that we want to have also goes by bringing out the truth or making something correct, correcting a wrong. And what I have on here is a picture of a forest fire. Back home, we were only about 40 miles away from something known as the Creek Fire, which was a huge, devastating wildfire that filled our area with smoke for weeks. It was terrible, terrible, terrible. But after the fire, what happens? Life rejuvenates. Okay? It corrects itself. Life comes back. And in fact, we know that forest fires are necessary to keep a forest thriving, right? So that's the type of judgment that we're talking about, is correcting a wrong. In addition to that, the art of redemptive suffering. Now, not everybody can get there very quickly. Redemptive suffering was something that St. Pope John Paul II was an excellent example of, especially during the latter part of his life, even during the earlier part of his life when he was shot. But especially in the latter part of his life, where he openly suffered. But in connection with putting it together on his cross, his own cross, and bringing it together to the Lord and combining it with the cross of our Lord for the purpose of someone else. Again, another topic for a talk that can go hours. An example of this is that, going back to my own depression, during the throes in the middle of the night where I was pouring out tears and heartache, I asked the Lord to take this from me, but I specifically asked the prayer, and I always do, your will be done. That's what I want to have happen. I want your will to be done. And if it means that I have to go through this suffering so I can do something better for somebody else, then let me have it. I will take it. This is my cross. In redemptive suffering, we identify what it is that's causing us that despair or ailment or problem. We identify it, we name it. In my case, oftentimes it was betrayal that I was feeling. Betrayal. I'm going to hold on to this cross of betrayal. And Lord knows He went through the ultimate of betrayal, didn't He? He knew what I was experiencing and what I was feeling. I named it, I felt it, I held on to it, I could feel the roughness of the wood, I could feel the splinters coming off of it, and all of that was, of course, an emotional pain. But I held on to it for the sake of somebody that I didn't know who could find redemption from their ailment, who was suffering much worse than I am. And lo and behold, look at what happened. Well, all at the same time, all of this happened, where I've gone out and met thousands of people and talked about this very topic. Suffering without Jesus just simply hurts. We also have the benefit of the mystical body, all of us here. I think all of us now have an investment in each other's lives. We're just simply meeting here for one night. Some of us haven't met before, some of us have, but we now have an investment in each other's lives. We can also be life-giving in our suffering. Something known as reflective grace, where if we're bedbound, and I see this in our homebound ministry often, bedbound, the person that we're ministering to is actually giving us life back by allowing us to minister to them. Okay? Reflective grace, that's something that my pastor, Father Seamus Rowland, just taught me just this week, reflective grace. Felix culpa is another term, another concept that Monsignor Gerald Berenda taught me. God rest his soul. He taught me during one of his homilies many years ago. And if during the replay of this talk, if we have any priest listening to us, we listen to your homilies. So make them good. Right? And yeah, so I've told this many times to priests. We're listening. So you look out there, and it might seem like we're not listening, but we're out there. We're listening to you. So don't tell us about what you think about the football score from last night. Tell us about what the gospel said. Okay. Anyway, when bad things happen, God can give us the grace to make good come out of it. Felix culpa. St. Augustine talked about it. St. Thomas Aquinas talks about it. Okay. I'm going to just give you one example of this for the sake of time. Mr. Don Ritchie. Don Ritchie, God rest his soul, was a resident of Australia. This area is known as the Gap. The Gap is an area, one of those iconic, beautiful areas that tourists go to and flock to and go see, just like the Golden Gate Bridge, as you see on the other side. Just like the Golden Gate Bridge, people would also go there and commit suicide. They would jump off the cliffs into the ocean to their deaths. Mr. Ritchie happened to own a house literally across the street from the Gap. And in front of the Gap, there's a trailway where people walk. He had this big picturesque window that he would look at this wonderful view, and he began to realize or recognize when someone was contemplating suicide. Oftentimes, it was a lone person who would be walking back and forth in obvious despair of some sort. And what he would do is he would go out, engage them in a conversation, and invite them into his home for a cup of tea. Simple interaction, just human beings talking with one another. He's credited by the government of Australia with saving 250 lives. His son has said it's actually closer to 650 lives that he saved, just simply by interacting with them. So what's that story for us? Listening equals hope. Okay. We recognize those symptoms happening, especially if we're youth leaders or catechists, and we see that one kid that's sitting off in the corner, arms folded, maybe crying. Okay. Engage. Okay. Hey, how's it going? I see you're out here. Looks like you're having a rough time with things. Why don't you tell me about it? Okay. Engaging. Listening to understand. Not putting words into their mouth. The conversation is not about us, not about what we say. It's about being present and listening. Listening. Don't interrupt. Don't think about what we're going to say next. You can certainly pray, Lord, give me the words to say that he needs to hear, he or she needs to hear. Allow silence. Let that period of silence go by. Deep breathe and control our own fear. So those fears that we felt when we heard that 911 call earlier, those are the fears that will probably stir up in us, right? And simply come out and ask the question. Sometimes when people are feeling like you are right now, they're thinking about killing themselves. Are you thinking about killing yourself? Straight out, just like that. You're not introducing a concept to them. You're not encouraging them. You're asking them to share with you what it is that the despair that they're feeling and how deep they are with that. If they say yes, oh my God, you don't want to do that. Oh my, you don't want to freak out. What you do want to do is keep yourself under control. Say something along the lines of, a lot of times people feel that way, and I'm sorry that you're going through, but we can help. We can find a way to help you. So how do we do that? Think in terms of body, mind, and spirit. This is, body, mind, and spirit was something in the old days that nursing used to just automatically get involved, but then they shaved off that spirit part. Lo and behold, it's beginning to make a comeback for good reason, for like I showed you earlier. We know that 70% of physicians and scientists have a belief in God. Actually, I think it's 75%. It's higher than that, 75%. So, fortunately, we're starting to bring that back into our care of the person. And for Sally and I, we introduced it in our clinical care many, many years ago. But the first thing is, a person that is in despair, encourage them to see their physician, the primary care physician. Doesn't have to be a psychiatrist. In fact, go to the primary care physician, because that person is going to have the overall health picture of that person. They're going to know what their medical history is. They're going to know what medications they're on. They're going to be able to do some testing on them. It could be a physiological issue. It could be both a physiological and emotional and mental health issue, in which case they can prescribe the medications that are necessary to get the ball rolling, to start that treatment regimen. And then they can move on into more specialized therapy after that. But start with the physician. The next step is to find a counselor. Rufy Sandoval was my counselor. Wonderful. Did a great job with cognitive behavioral therapy for me. But getting a counselor is crucial as part of the regimen, treatment regimen, because we have to get that stuff out and we have to explore certain things within ourselves. Okay. And then, of course, the spirit. Go see your clergy, go see a priest, go see a minister. Whatever our faith expression is, get involved with that. For us as Catholics, of course, we have the sacraments. Receive all of our sacraments, starting off with confession. Sometimes one of those life experiences has to do with our own sinfulness, where we have to get it out and get it out of ourselves, regaining that absolution, being fed by the Eucharist. And then certainly we can become anointed or be anointed through the anointing of the sick. It is highly appropriate for a person that is depressed to be anointed. And if they're not getting better and seem to be getting worse, they can have it again. So all three of those things were the things that I did. Those were the steps that I took. And it worked. It worked. Now, with regards to medications, they don't always work in the same way for all people. And also, the medications take a couple of weeks before you start seeing an effect. Sometimes they don't work, in which case a combination of medications have to be tried, different dosing levels, and that can take months. Sometimes it can take years in order to find the right combination of medications that work for that particular person. And then for us that are leaders, especially for group leaders, get trained. There's a whole slew of different types of training that we can go to. There's a 1 hour online training, QPR, question, persuade, and refer. I used many of the concepts throughout this talk of QPR with you. Of course, not nearly as extensive as they would go through. Assist, the Applied Suicide Intervention Skills Training, is a 2-day program. And I've been able to do all of these types of trainings and highly recommend them. The one training I have not done is the ASK training. This is available here for educators in Texas. But get trained. And what this training will do is help us to the things that we talked about throughout this talk. Recognizing, intervention, refer.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy. I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual...
Acting really down, crying all the time for no good reason.
Or getting really mad, not able to sleep, or sleeping too much.
Shutting her friends out or giving her stuff away.
Acting reckless, drinking, using drugs, staying out late.
Suddenly not doing stuff he used to love.
Or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed.
Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself. It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said something.
I wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask. They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask.
In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes.
Well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
You're making too much of this.
That boy's not worth killing yourself over.
That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself. What you do say is,
I'm sorry you're feeling so bad. How can I help?
We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves. Adults and kids. Most of them never try it, but some of them do. So if your kid says,
I'd be better off dead.
I can't live with this.
I'm gonna kill myself. Take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Sometimes kids want to kill themselves because something happened. A breakup, a failure. But sometimes it goes deeper, and it's not going to go away by itself.
Get some help. Talk to your doctor.
Or a counselor at school.
Or your minister.
But don't just let it drop.
And make sure that your kid always has someone to turn to. Someone he trusts.
Make a list together, right then. 3, 4, 5 names.
Put a suicide hotline number on there too.
Have him keep that list in his wallet, so he always knows where to turn.
Make sure your home is safe.
If you have pills she could use to hurt herself, lock them up.
If you have a gun, don't just lock it up. Get it out of the house. The bullets, too.
And one more thing. If you think your kid might be about to hurt himself, don't leave him alone.
Take him to the emergency room.
Call 911 if you have to.
We all have our ups and downs, but sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Ask straight out. Are you thinking about killing yourself?
Don't wait until you're sure. Trust your gut, because it never hurts to ask.
And it can make a big difference. All the difference.
In your kid's life.
So, 988, the number that was shown at the end of that video, it still works, but it has been shortened to 988. So if we come across a situation that we want to refer someone to, we ourselves can call 988, explain the situation, and they will help us get help for that person, or that person can call themselves. They can also text it, or they can chat on that line. The good thing about the National Lifeline is that it comes back to the locale from where you're calling. So it goes to the National Center, and then it comes back to the location from where you're calling, so that the people that are actually helping are here locally, the people that you can refer to or get help from. That's the first resource that I would point a person to if you're not sure where to go with this. There are other resources up there. The other one is the mentalhealthclinics.org. This is a national database of all the mental health clinics in the United States, and you can go click on your state and your locale to find out what is available to us locally. And then on the bottom there is my own email address. Please feel free to email me if you have any questions. I particularly want to know if there's something that you can teach me, and even specific, and especially specific to East Texas and the culture as we had started out to begin with. I'm going to leave this. So what you're saying is that the kids will probably express that to their friends prior to you, and that's very true. Although they will express it to the parents in ways that we would not expect it. Oh, I'm just going to kill myself. Okay? Take that seriously. Take it seriously. All those cases that I was telling you about earlier that we reviewed, a lot of times that happened. I just didn't believe it. I didn't believe him. I thought he was going, nuts. And then he actually does the act. Well, it goes on with the entire parenting thing, right? We have to be able to be engaged with our kids, not just on a one-off, but throughout their entire lives. I know that shooting hoops with my sons was one of the ways that I communicated with them, and I would check in with them. But it might be a sentence or two, and then half an hour shooting hoops, but that's where it came through. And I remember one distinct time where one of my boys came up to me while I was cooking dinner, and he said, "Dad, I got to talk to you about something." Everything went off. Laser focus. Yeah, son. Thanks for opening up. Go ahead. And we talked. So it's that establishment of relationship with our kids, certainly. Again, another topic for another day. Thanks very much for putting up with us. That was almost a couple of hours.